Hi students, today I'm going to explain about thalassemia in brief. So what is thalassemia, right? It's a hemolytic anemia. Sorry, it's a hemolytic anemia and it comes under hemoglobinopathies. Hemoglobinopathies means disorder of hemoglobin. First of all, what is hemoglobin, right? Hemoglobin is a protein which helps in oxygen transport, right? And this hemoglobin consists of two parts, heme as well as the globin part. Heme part consists of the iron as well as the protoporphyrin. We can see here iron and in which protoporphyrin. And normally the hemoglobin consists of two globin chains, alpha as well as beta. There are two alpha as well as two beta globin. And as the name suggests, thalassemia, it's most commonly seen in the people from the Mediterranean, Middle East and Indians. And it's autosomal recessive. The mutations which leads to decreases of these alpha globin or these beta globin are known as the thalassemia. As we know, the Hb, that is hemoglobin, is a protein which helps in the oxygen transport. If any disorder which affects this hemoglobin, the transport of oxygen is also getting affected, and which leads to tissue hypoxia, and it all can also lead to death. So it's the most common region is around the Mediterranean Sea. As we said, there are two types of thalassemia, beta thalassemia as well as alpha thalassemia. And beta globin, guys, beta globin, the gene which codes for beta globin is present in the chromosome number 11, and the gene which codes for the alpha globin is present in the chromosome number 16. And the most common form of thalassemia is the beta thalassemia, and it's mostly due to mutations. And alpha thalassemia, that is the decreased synthesis of the alpha chain, it's less common and it's mostly due to the gene deletions. And here we come to the introduction part, and we know that it forms protection against malaria. If a patient with thalassemia has any is contradicted with any malaria, the patient will have severe or mild symptoms only than that of the normal patients. And mostly this thalassemia is caused due to some mutations which is happening in our gene. The most common two mutation which leads to thalassemia is splicing mutation, which is the most common cause of the beta thalassemia, and chain terminator mutation, which is the most common cause of the beta not thalassemia. And here we should also know about the normal adult red cell consists of three types of hemoglobin: HbA, HbA2 and fetal hemoglobin. The HbA consists of alpha 2 and beta 2, and it's constitutes the most it's constitutes the major part of the hemoglobin. And HbA2 consists of alpha 2 and delta 2, which constitute about 2 to 3.5%, and the fetal hemoglobin, which consists of 2 alpha as well as 2 gamma chain, and it consists of less than 1% of the adult human hemoglobin in the red cell. And here we can see a patient with thalassemia. Here the patient presents with dysmorphic facial features. The patient will have a dysmorphic facial feature such as frontal bossy, thin nasal bridge, as well as prominent cheekbones. Why these prominent cheekbones are present in the patients with the thalassemia is that it's mostly it's due to extra medullary hematopoiesis. What's meant by extra medullary hematopoiesis? It's that mostly hematopoiesis occurs in a bone marrow, right? What is hematopoiesis? Production of the red cells. It occurs mostly in the bone marrow. But when our bone marrow is has any problem such as any aplastic crisis or any problem in the red cell production, ineffected erythropoiesis in the bone marrow due to some distortion or some tumors, this hematopoiesis shift to any other organs such as liver, spleen, or in bones too. In any other bone part like skull, it shifts to any bony prominence or any bony area or any parenchymal organ, and it's known as the extramedullary hematopoiesis. The hematopoiesis occurs outside of the bone marrow is known as the extramedullary hematopoiesis. Now, in thalassemia patient, there is ineffective erythropoiesis and ineffective erythropoiesis. So this hematopoiesis shift to any other part of the bone of the patients, and the bone becomes thick due to the erythrode hyperplasia, and these prominent cheekbones has been seen in the patients with the thalassemia. Now we can come to the pathophysiology behind it. We know that the normal red cell consists of 2 alpha as well as 2 beta chain constituting the HBA, right? It forms normal erythroblast. It's a normal erythroblast in the bone marrow. See, we can see 2 alpha as well as 2 beta. Now, due to the reduced beta globin synthesis, there is a reduced beta globin synthesis. Here we can see there is a reduced beta globin synthesis, so the alpha remains alone, right? Because this alpha remains alone, there is no beta globin present for the alpha to bind. This alpha together, many alpha globins form together and form an insoluble alpha globin aggregate. Why this insoluble alpha globin aggregate form? Because of the deficiency of the beta globin there, right? Due to the deficiency of this beta globin, this alpha globin, the whole alpha globin, it's insoluble and it forms an aggregate, and it it produces red cell membrane damage, and it causes red cell membrane damage. So there is a defective red cell production. There is a defective red cell production in the abnormal red cell production in the bone marrow. Due to this red cell membrane damage, most of the erythroblast dies within the bone marrow itself. Due to the red cell membrane damage, it dies within the bone marrow and it undergoes apoptosis inside the bone marrow. Due to this apoptosis, the more erythroblast dies inside the bone marrow itself, so that it causes ineffective erythropoiesis, because most of the erythroblast dies in the bone marrow due to the red cell membrane damage, which is caused by this insoluble alpha globin aggregate due to the deficiency of beta globin, right? Okay, there is a deficiency of beta globin. There is another chance that there is another chance that there is a deficiency of beta globin, and there is another chance that there is a decreased production of HbA, right? That is alpha 2 beta 2. HbA is the normal adult hemoglobin, where the 95% of the normal red blood cell consists of a 95 HbA, right? If it is reduced, our red cell become hyperchromic, hypochromic, right? Hypochromic. It becomes under hemoglobinized, right? It becomes under hemoglobinized. So we can see microcytic means small, hypochromic blood picture. Microcytic hypochromic blood picture. And we, in iron deficiency anemia too, we can see this microcytic hypochromic picture, but we can differentiate this thalassemia and iron deficiency anemia with the help of osmotic fragility test. in which the osmotic fragility test in the iron deficiency anemia shifts to the right because the red cell is fragile, and in thalassemia it shifts to the left. The curve shifts to the left due to rigid red cell. Okay, and it's what the difference between the two. And next is the beta. We know that there is a reduced beta globin, right? Reduced beta globin, and we also know that there are this due to this reduced beta globin, this alpha 2 doesn't have beta globin to bind, so this alpha binds with the gamma to increase the production of HbF, and alpha to delta 2 which increases HbA2. So in thalassemia we can see that patient will be having less HbA, more HbF and HbA2. So now we can see that there are decreased beta globin chain. There is a deficiency in the beta globin. So this alpha binds with the gamma 2, so which increases the HB fetal hemoglobin, and this alpha binds with the delta 2 to increase the HbA2. And we can also see there is a decreased HbA synthesis because of the decreased beta globin and causes microcytic hypochromic blood picture. And alpha chain alone, it forms aggregate, insoluble aggregate, and red cell membrane damage, apoptosis, and ineffective erythropoiesis. Due to this ineffective erythropoiesis, right? Due to this ineffective erythropoiesis, there will be erythroid hyperplasia, increased iron absorption, which sometimes cause iron overload, increased production of erythroferron, which leads to decreased hepcidin, which causes this increased iron overload and causes secondary hemochromatosis. And patients, I already said, the patient present with dysmorphic facial features, mostly children's with dysmorphic facial features with anemia, they usually present. And we can also see, I already said that there is extramedullary hematopoiesis. The hematopoiesis in thalassemia shifts to this color. We can see a crew cut appearance in army people who used to have a haircut like this, right? It's known as crew cut appearance. Crew cut appearance. And at last we have 3 type of beta thalassemia, that is beta major, beta minor, beta intermediate, and beta minor. They are homozygous. Beta minor, or it's also known as straight, it's heterozygous. And beta intermediate, it's asymptomatic and milder version of the beta major, where the beta major beta thalassemia major needs they are transfusion dependent, and where the beta intermediate is transfusion independent. And hemosiderosis and secondary hemochromatosis, the two manifestations of the iron overload, inevitably occur, and we will use chelation therapy. It's transfusion dependent, so there is a chance for iron overload. So we can also use, for a patient who is undergoing continuous transfusion, we can give them iron chelators, right? we can give them iron chelators. And as I already said, beta thalassemia, they are beta minor, they are asymptomatic, and the beta intermediate and beta major, they are severe, and beta major requires transfusion, they are transfusion dependent, and beta intermediate is transfusion independent.